communication has been a topic that I have been fond of through all of my schooling, from freshman year up until now. And I was very excited to have the chance to do this topic. So starting off, just as a basis for my definition of health communication, I used Rogers' definition, which was any type of human communication whose content is concerned with health. So you might be thinking that's like super broad topic, and this is a very broad topic in itself. All of us deal with health, and a lot of us think, when we think of health communication, we think, oh, I'm not a medical doctor, do I really need to know about health communication? But I would ask you to ask yourself, how many times have you been to the doctor? Was it a planned visit? How did that communication go? Different things like that. And this is a lengthy quote, but very fundamental to health communication. It states, information is fundamental to choice in making informed decisions. Without information, there is no choice. Information helps knowledge and understanding. It gives patients the power and confidence to engage as partners in their health service. Now, I included this quote because health communication is fundamentally about the exchange of information about health. And as we move forward, there we go. Here's an overview of what we're going to talk about today. First, we're going to talk about the significance of effective communication and ineffective communication in healthcare. Then we'll move to the history of health communication. Then on to theories and models of health behavior / communication. Then we'll move into communication between patients and health professionals, which is often what most people think of when they think of health communication. Then we'll move into communicating with particular populations in healthcare, so what kind of patients our doctors are dealing with, communication of difficult information in difficult circumstances, and then finally, what doctors can do with the information with communication skills training. So what is the significance of health communication? Healthcare providers who communicate well with their patients are more likely to secure positive outcomes for patients, themselves, and others. And I would just have you take a minute to think about that. Communication can contribute to better outcomes in health. It's fundamental to the health system. They're more likely to make more accurate and comprehensive diagnoses, detect emotional distress in patients. Patients are more satisfied, and they actually agree to follow through with the treatment that they have collaboratively decided on. Patients who have dealt with professionals with good communication skills have shown to have improved health and recovery rates. Schofield noted that effective communication was a drug that could be prescribed. Whereas effective communication showed all these beneficial results, ineffective communication led to a whole range of negative outcomes. These include patients not engaging in their health services, refusing to follow the recommended health behaviors, failing to adhere to their treatments, failing to even cope with the illness at hand. And more legal things like litigation or death from ineffective communication between patient and doctor. In a nutshell, as Pettigrew and Logan in 1987 stated, communication promotes both health and illness in society, and it makes the system run at an optimal or marginal effectiveness. Whole range of negative outcomes, yeah. There we go. So, with this basis of the significance of health communication, it's important to acknowledge that the emphasis shouldn't just be about communication. It should be about effective communication. If we're talking about effective communication with healthcare professionals, securing better outcomes for patients, it's not just communication, but effective communication. As I talked about, ineffective communication can be extremely detrimental to patients. We need to impart the right information to the right people in the right way at the right time. Simply providing more information cannot be the goal in and of itself. Communication needs to be patient-centered, informative, and needs to promote trust and confidence. As McDonald noted in 2004, good communication between patients and medical staff is important from the very first encounter because it sets the basis for all future transactions. You can think about if you go to a doctor and right off the bat you don't like them, your whole medical experience from that point on is going to be harmed. So moving into the history of health communication. Significantly, in the UK, they came out with a patient's charter, which informed patients that they had the right to be given a clear explanation of any treatment proposed, including any risks involved in alternatives. And like now in this present age, we take that for granted. Oftentimes, with the paternalistic view of health communication, the doctor basically decided what was the best for you, and you weren't given an explanation or even the risks involved, so you could decide out of your own autonomy. And then at the same time, Toronto Consensus Statement came out about the relationship between communication practices and health outcomes. So this is both right around the 1990s. And this statement made 8 key points. The first being communication problems in medical practice are important and common. The second being patient anxiety and dissatisfaction are related to uncertainty and the lack of information. Doctors who misperceive the amount and type of information that the patients want to receive. The fourth being improved quality of clinical communication related to positive health outcomes. After these events in the 1990s, health communication became a central part of effective healthcare. No longer was it just an add-on to the medical practice. As I talked about earlier, health communication effectively can be a drug in and of itself. And so around this time, researchers and the medical field started to realize how important and central health communication is to their practices. I often think about a lot of our communication studies, and if you think about management, it is its own theory, and oftentimes communication is added as an add-on to management rather than the central focus of management. So next time we're going to talk about the models and theories of health communication. I'm going to talk about 3 theories: the health belief model, the theory of planned behavior, and Norton and Nortonhouse's model of health communication. Okay, so our first theory is the health belief model. The health belief model was originally proposed by Rosenstock in 1966 and was further developed by Becker and Rosenhaus in 1984. Decisions concerning health decisions are people's subjective perceptions about a potential health threat. According to this model, a perceived threat motivates people to take actions, but beliefs about the potential behaviors determine a specific plan of attack. So essentially, you have this basis of how you feel and how you perceive a health threat. And it affects your behavior about what health outcome may be. And so this works well for things like a healthy diet. So you see the threat of becoming obese, and then you outweigh the threat with working out, and your behavior is working out. But the criticism of this model is that it's very static, and it doesn't account for situational thinking factors. This is all on a subconscious level. Our next model is the theory of planned behavior. In this theory, it attempts to link health beliefs directly to the behavior. It proposes that intentions are plans of action in pursuit of behavioral goals. Intentions result from three factors: the attitude towards the belief, the subjective norms, and the perceived behavioral control or self-efficacy. This means in order to influence health behaviors, health communication needs to address these three factors. The theory of planned behavior can predict a broad array of health behaviors, including exercise, vitamin taking, sunscreen use, and contraceptive use. As far as evidence goes, Connor did a study in 2000, and he reviewed 185 individual studies that had been carried out and found that the theory accounted for 40% of a change in behavior and 27% of actual changes in behavior. Again, the con of this is it's static. It's not time-based. The model is very subjective, and it neglects social variables, and it isn't specific to the relationship between different health beliefs. And finally, I have Norton and Norton's house model of health communication. This comes about 20 years later of the other two. It believes that health communication refers to transactions between participants in healthcare and health-related issues. This model shows a series of factors, most notably relationships and transactions and contexts, that can impact the interactions in a healthcare setting. As you can see, it shows the different relationships that can happen in health communication. You have your doctor to doctor, doctor to patient, and then you have the patient to their loved ones or significant others, and then the significant others to the health professionals. What I really like about this model is it isn't just doctor to patient. It shows kind of the variance that is in the health communication field. So these health transactions are both verbal and nonverbal communication. As you can see, the kind of strange spiral in the middle, this shows that health communication is ongoing, transactional, and is an interactive part of who we are, whereby different participants influence each other's communication and interaction with each other. Healthcare contexts are settings in which health communication can occur. So the healthcare context might be I'm at the doctor, or I'm in the ER, or I'm in the waiting room. Wherever health communication can take place would be the healthcare setting. Okay, so moving into communication between patients and healthcare professionals. The typical stereotypical view on health communication that it only is attributed to this. Health communication has a number of goals for both the doctor and the patient, essentially. Okay, so I'm going to break it down here for you guys into sections of communication between patients and health care professionals. So first I'm going to talk about communication and relationship building. This is the communication between the doctor and the patient and how they build relationships. Successful medical encounters will usually depend on developing and maintaining a relationship, which in turn requires effective communication on both parts. According to Burton and Dimbley in 1995, all relationships are conceived, affirmed, conducted, and even broken by the use of communication. Relationships are developed through self-disclosure, and the quality of the relationship depends on the positive use of social and perceptual skills. Empathy and trust are important, obviously, in the medical field for both the patient and the doctor, and this builds their positive relationship. As far as this goes, I know you're all comm students and you're thinking CPM, communication privacy management. This falls a lot into it. What the doctor will disclose and what the patient will disclose uncertainty and that trust is built between the two of them. But when you think about it, in the medical field, trust is very vulnerable and can be broken if one per se does the wrong thing. So the next topic is communication in healthcare encounters. Elderman in 2000 suggested that most clinical encounters can be thought of as an interaction between two distinct cultures, the medical culture and the culture of the patient. This is important because it's a blending of the two cultures, and you're not seeing them as one health communication culture. The two groups obviously think very different about health and illness. The patient's agenda will reflect their own unique idea of illnesses and their experience with the medical field up to the point. And obviously, either the doctor and the patient are going to have varying communication styles, and so it's usually in part the doctor's duty to adjust their style to that of the patient. For example, women doctors take more time with their patients. They're more interested in addressing their social and emotional needs. Oftentimes, healthcare providers will match a tone to what they're talking about. So if you're dying, it's a serious tone. If you have a chronic illness, it's trying to be a hopeful tone. Nordenhouse and Nordenhouse noted that in addition to specific professional and personal characteristics, relationships between healthcare providers and patients are often affected by uncertainty in the roles that each of them are playing, uncertainty in who's responsible in managing their healthcare. Is the patient going to take the lead, or is the doctor going to have most of the control? And I think the biggest thing in patient-doctor relationships is the asymmetrical balance of power. The doctor obviously tends to have a lot more power, and a lot of that comes with knowledge, and usually the patient is very vulnerable. So like if you break your back, you don't have a lot of knowledge about the surgery that you're going to need to fix that. Yeah. And Davis and Fallowfield in 1994 suggested that the majority of communication problems occur when the healthcare provider doesn't introduce themselves, doesn't clarify things, doesn't ask the patient to ask questions, or have them repeat back what they said to them so they can understand what they're being told. And the big thing with this communication in the healthcare encounters is the jargon. Obviously, that's a big barrier for healthcare professionals because jargon is pretty much your bread and butter. And next, we're going to talk about specifically doctor-patient communication. According to Ong in 1995, the doctor-patient relationships is one of the most complex interpersonal relationships. It involves working with people in non-equal positions. It's often non-voluntary. Obviously, if you broke your back, you don't really have an option if you're going to the doctor. You didn't decide to go. Concerns of vital importance. Maybe your life hangs in the balance. Maybe your back hangs in the balance. And fourthly, it's obviously emotionally saturated and requires close cooperation. Are you going to do PT? How do you feel about never walking again? Stuff like that. Obviously, that's an extreme example. Pauling in 2004 described a simple research project that asked doctors and patients what made a good doctor. So the doctor said that a good doctor was someone that was capable of diagnostic ability, and the patient said that a good doctor was someone that listened. Obviously starkly different from each other. Delmore in 1998 found out the top 3 categories that most influence a patient finding a doctor to be a good doctor. And it was basically, how well does the doctor communicate with the patient? Can they explain medical jargon in layman's terms? And do they listen and take time to actually know you and ask questions about you? In contrast, the doctors rated the most important thing as the numbers of years in med school and where they went to med school. So, totally different ends of the spectrum as far as what view is important. So Ong in 1995 suggested 3 basic different purposes of communication between doctors and patients. You gotta create a good interpersonal relationship. You gotta effectively exchange the informationship. And you have to bring it all together in your medical decision making. So a blending of the two things that make a good doctor for the patient and the doctor kind of blends those two things. So in the past 20-some years, medicine has shifted from paternalistic to patient-centered. Essentially, the doctors aren't just deciding what is best for you. Now, especially in Western medicine, it's like a collaborative, cooperative situation. They tell you the risks and treatment. Like I showed the Department of Health Code, you have a right to have the risks explained to you. Patient-centered medicine stresses the importance of understanding the patient's experience with their illness. So not just the fact that your bones are broken, but how does that make you feel and how is that going to affect your recovery? And next we're going to talk about the communication between healthcare providers and patient's family. This is often something that's left out. Because when you think of being a patient, you think that you're in control, but obviously your patient, as a patient, your family is a huge part of your illness process, unless you live alone, I suppose. But basically, Bloom noted in 1996 that significant others were key in making it through life stresses and coping with your illness. Having to communicate for doctors to family members is often a difficult intricacy, because oftentimes they may have different views than the patient, and they have to deal with their communication style, especially if they're on 2 different sides of the spectrum, like perhaps your family wants you to have surgery, but you want other options. The doctor has to be able to effectively communicate with both parties. Norton and Norton House in 1998 pointed out 2 problems that arise from this situation, and it's privileged communication and filtered information. So privileged communication is where the doctor tells the family things that the patient doesn't know, and then filtered information is where the patient tells their family what the doctor said, and often this is hard because it's medical jargon. You forget, if any of you have had a medical experience, you go to tell your family, it's not the exact same as what the doctor said. So that's obviously a problem in the health communication. And finally, communication between different healthcare professionals. And essentially, this is key for a happy work environment. Being able to work together is good for the professional and is good for the patient. Say you have a specialist in your specific disease, and you have your family doctor that's managing all the meds that you're on for this specific disease. If they're working together, you have a lot better outcome than if they don't talk to each other at all. And here's a little cartoon about medical jargon. And at the waiting desk, you get your medical jargon dictionary. Thought it was cute. Okay, so next we're going to move into communicating with particular populations in healthcare. Specifically, this is who are the doctors communicating with, and how can they make an effective communication between themselves and the patient. So first we're going to talk about older adults. So obviously, life expectancy of people has risen, and so this has become a greater issue in health communication. The Department of Health in 2001 said 80% of people over the age of 75 take more than one medication, and then 36% take more than 4 medications a day. So obviously a lot of health encounters going on in the older population. In general, studies have shown that doctors towards this age range of patients are abrupt, indifferent, and dismissive. The book gave some suggestions, such as don't yell at people with hearing loss. They just need to be talked to slower and with a more resonating tone, and to sit closer to them so they can read your lips. When communicating to someone with cognitive impairment, they said it was very necessary to allow the patient to have time to process it and then talk to them about what you just specifically said to them. It said absolutely don't resort to baby talk with someone with cognitive impairment, which I don't like that either. So, also it said healthcare professionals shouldn't just specifically talk to a third party. So, like if you have Alzheimer's in your early stages and your family members there, the doctor needs to talk to the patient, not the caretaker. And that was huge for the older generation. Next was communicating with younger children and parents. Obviously, the dynamic between younger children and parents is hard because it's hard to explain medical jargon to an adult, let alone a child. And oftentimes, the parents and the children are on two different levels with the illness. The book said that the parents were better at describing the child's physical symptoms, but they couldn't effectively describe how the child was feeling about their symptoms or how they feel. So they said it was very important that it was collaborative between the doctor and the younger person and the parents. It also talked a lot about how children perceive illness and the different stages. When you're younger, you perceive illness as an external factor and you don't really understand it. And then when you're right in the middle, almost a teenager, you understand illness as contagious or apart from yourself. And then I believe it said 11 or older, you become fully understanding of what illness is. It said use a calm, reassuring voice and understandable terms. Talk directly to the child. Again, not in a third party. It also said if there's different disagreements between the parents and children, the healthcare professional needs to be the mediator in the situation. And next, communicating with adolescents. Barry said that adolescents are difficult to talk to at any given time, let alone in health communication settings. They said that adolescents were least likely to trust a healthcare professional and most likely to not do what the healthcare professional said. So the advice was to tell them multiple times and let them understand it, because they said it takes the adolescents 3 times longer to accept what illness and treatment they've been given, especially with adolescents that have lost some sort of functioning. Being up in Mayo at the rehab treatment for pain, a lot of the younger kids didn't trust the medical professionals, and they weren't in terms of their chronic illness yet. And next, communicating with angry patients. Have any of you been angry patients before? I know I have. So this is the final category. And oftentimes the healthcare professional is bombarded by the parents or significant others and the patient at the same time. And they said a lot of professionals try to justify that the patients are being unreasonable. They said that's about the worst thing you can do because it's not a rational situation. They just said reflect on it, relate to them, review it, and then they said, just have an open discussion. Don't try to tell them that they're wrong, and just give them more information and more time and be understanding and caring. So next, we're going to talk about communication of difficult information in difficult circumstances. First, we're going to talk about communicating information about risk and uncertainty. Risk and uncertainty is the bread and butter of health communication, especially when you're talking about serious illness. Oftentimes, feeling about your own body, and feeling that way, like, if a medical professional is also uncertain, there's like a sense of deep fear. And one of the things I loved about this section was how doctors and patients rate side effects of medication. So they asked college students if acne, what to rate acne on the symptoms chart, and they said it was like highly bad. And then doctors said it was insignificant. So I thought that was really funny. And also the labeling, where doctors would say it's very likely that you might, and this is very likely was like 20%. And to the patient, very likely was 50%. So you have the huge gap, which is why it's important that all the labelings on medicine are there. Next, we're going to talk about conveying bad news, which is always wonderful. The practice of medicine and healthcare, inevitably, as a doctor, you're going to present bad news at some form, whether it's a medical mistake, or whether it's just an illness. It can range from you need an operation, to you need to go to PT, to you're dying, or you're telling the family about an unexpected death. In all cases, obviously, good communication is essential. Most people need time to absorb the information that you're giving them, and you don't want to overwhelm them with too much information. But they also said, don't get too attached, because then you can result in burnout using your emotional self. They said when you're breaking a bad news, choose a quiet room, convenient time, start with a preparatory statement, get them ready for what you're going to tell them, allow time, be warm, empathetic, respectful. Lloyd and Bohr in 1996 recommended that breaking bad news requires empathy and starting with what a patient already knows, understands, and finding out what they want to know. So letting the patient kind of steer the course for what's going to happen. And then next is communication with dying patients. The biggest thing that I got from this was no news is not good news. It's an invitation for fear. So oftentimes with dying patients, some healthcare professionals are hesitant to bring up the bad news or to tell them because they realize the emotional impact that will be inflicted. But the book said, absolutely, as soon as you know, you need to inform all parties involved because no news is not good news. And the fear can contribute to negative health outcomes. Next, like all communication, we have the ethics of health communication. And Childress in 1995 outlined the 4 basic principles central to medical ethics. First, respect for patients' autonomy. They have all of their options and they're able to respectfully choose what they want to, regardless of how you feel as a medical professional. The next is the benefit of the patient. The healthcare professional does their best to work on the behalf of the patient for beneficial outcomes. Next, it's the principle that states that healthcare professionals should not harm their patients. This is HIPAA, and I'm sure Thayer will go into that. Yeah?
Yes. Sorry.
And the next is justice.
Still you smoke.
The next is justice, which requires all healthcare professionals treat patients the same. Next lastly, we have communication skills training, which is what doctors can do with all this health communication information that I put out there today. Essentially basic communication skills. Like we've all had a good foundation of communication skills. Oftentimes you need that layer beneath you before you can delve into some of the hard topics that I just explained. Managing conflict, which we talk about in a lot of our communication classes. This is going to be key for medical professionals to have a basis in conflict, not only theory but practice. And then it showed different approaches for teaching medical professionals these things. And it was doing the job, which is basically just sending them out there and hoping that they can figure it out, which works some of the time. And the best one was modeling the master. So essentially you're apprenticing the health communication techniques of your superior. Then direct training and doing based training. They said this was the least effective. This is just working in a classroom and then expecting to have good results when you go work with patients. But obviously health communication isn't that static. And next, it actually talked about communication skills training for patients, which I thought was very interesting. They did some studies on training with patients, and the first was just having patients write 3 questions before they go to see the doctor. The next was high intensive intervention, which was practicing talking to a doctor, and this led to a positive change in their variables. They're more confident talking about their health outcomes. However, the study revealed mixed findings on patient satisfaction. So they were doing better effective communication, but they couldn't establish that the patient was more satisfied. And that's health communication.